including John Hopkins Medicine, Mubadala Healthcare, a subsidiary of Mubadala Development Company, Saudi Aramco, Siemens Healthcare, TVM Capital Healthcare, Ministry of Health Kingdom of Saudi Arabia, and the Government of Abu Dhabi Healthcare Regulatory Authority. He has excellent clinical and research training at prestigious US institutions like Johns Hopkins Medicine, Weill Cornell Medical College, State University of New York, and University of Pennsylvania, with further education and professional development at University of Massachusetts, Harvard Business and Public Health School. So we are very fortunate and lucky that we have such trendsetter leadership with us to share his experience. And for today, the panelist is Dr. Umar Hayat. You are quite familiar with him for his work, and he has been a regular panelist in the APPNA Merit Committee. And his background in pharmaceutical, life sciences, and practical experience both in US as well as in Pakistan in different spheres. So we are lucky that we have Dr. Umar Hayat, who is also going to share his experience and ask the pertinent question because he's a regular visitor to Pakistan in the urban area and the rural area and privy to the healthcare delivery over there. So I welcome all of you to today's session and webinar. So Assalamu alaikum and good morning, good evening, good afternoon, wherever you are. So we are going to formally request Dr. Muhammad Ali to open up and start his presentation. So over to you, Dr. Muhammad Ali.
Thank you very much for your kind introduction and inviting me to this prestigious and esteemed platform. I will walk through, framing the problem, what we see in Pakistan and what we have observed, and then walk you through the solution and the basis of that solution, why we think it will be sustainable and will have a long-term presence, followed by the current status of where we stand, what we have done in the last 1 year, and then correlating it with some of the global trends as well, so you get a more holistic picture that this change is not just relevant to Pakistan, but other emerging markets and even advanced economies, the same changes are happening. So, and I'll be more than happy to answer questions as we go or at the end. So the key question which I asked myself, and I'll walk you through this very personal journey as it happened, that, that what is the problem? What are we trying to solve for? And this is where, I had to relearn Pakistan, even from being Pakistan and being in med school here and everything. I had to relearn Pakistan, and I spent a good year or so just looking at everything that is published and understand what the challenge is, what we are facing. And this is where, when we look at, and I boiled it down to 4 main themes as we speak, where we thought the problems are. Obviously, the access to care and equitable access to care and the different shapes of access to care is one issue. Fragmentation of services, because a coherent, inclusive approach is missing, and there is a mismatch between the supply and demand. And this mismatch is not just infrastructure. This mismatch is between human capital as well, infrastructure, investment focus, the public sector focus as well. And then the underlying disease demographic shift, which is a norm or becoming a norm across emerging markets similar to Pakistan, which we have to realize. So until we not understand these issues, any solution will be short-term or a knee-jerk or a band-aid. And hence we took this approach of going down to the core of the problem and understanding what it is. And this is where, yes, the data is limited in Pakistan and we cannot find much data and so forth. But we looked at everything that has been published, whether it's by the government, whether it's by the private sector, whether it's the academia. And there are certain things which came out very clearly that the provision of care is concentrated. People tend to have to travel to larger cities. Otherwise, they're at the mercy of these mom and pop clinics, and they have to forego sometimes necessary medical treatment because of the expense and the cost distribution between different elements by the time they get to the care. Secondly, similarly, when they tried to understand the behavioral mindset in terms of what is important for people, proximity came out as one of the factors that everyone would like to see that the care is provided closer to. Despite the notion of how much healthcare spending is, Pakistan as a nation, as a country, tends to spend and continues to increasingly spend on healthcare, whether it's public sector or private sector. And estimates are that's already crossed $10 billion as of the last estimates in terms of healthcare spend. And the focus is shifting naturally where people are try to avoid a hospital, and if they can get to a clinic or a physician clinic or a multi-specialty and so forth, it's their preference to get care closer. So these are some of the key things which we learned across board. And then when you look at the demographic shift, I don't want to go into the detail of that. Yes, healthcare is poor. We already know that. We don't need to keep repeating. I asked the question to myself as well. These are the known things. What can we do about it? Hence, I looked at the disease as well, because the common perception has always been waterborne diseases or infectious disorders are more common than the others. But when you look at the literature, look at the data that has been published, there has been a shift in the disease demographic. It's almost splitting 50-50 between waterborne and infectious disorders and the lifestyle disorders as we speak. So Pakistan is no different as an emerging markets compared to other countries in terms of how the disease pattern has changed with so-called urbanization, modernization, and so forth. But that is a reality that is happening in Pakistan. And that has an impact on a solution naturally, because we all know that an acute care versus chronic care, it can be delivered differently. Looking at the spend, this is where the mismatch between what people perceive and what actually happens is important. And this is a common question I ask everyone, and you can ask yourself as well, that when you ask people what kind of healthcare system Pakistan has, everyone will give you that, oh, I think it's predominantly a public healthcare system, which is not true. So Pakistan is a privately delivered, privately financed healthcare. Government only spends about 1% of the GDP. Total healthcare spend is about 3% of the GDP. So 2% is out of pocket by people under private facilities in the private financing. So we need to realize that we're not a public healthcare system as we perceive it to be. We are financing and delivery care privately, predominantly in the country. Because of, again, concentration in larger cities, the perception may be driven by those images rather than the objective data, which when we look at, it shows you that 70 to 80% of the healthcare spend is out of pocket. So that has an impact on the solutions, that has an impact on how much people are willing to pay, because it is a necessity that will carve out from your other expenses. And just to highlight that this is, as I initially said, if you look at all the emerging markets, which are transitioning from frontier into emerging markets, similar trends are noticed. So it's not something that is unique to Pakistan. And you need to, on the other side, you need to overcome this gap to transition to an emerging and further on to a developing or developed economy. Without solving for healthcare, you cannot achieve that socioeconomic status that we all envision, and healthcare tends to get ignored to the bottom of the public spend at times. So this is a match that is hand in hand, and these demographic challenges, rapid urbanization, ineffective healthcare systems, expenditure trajectory increasing, and so forth. So we really need to take a pause at all these issues and then look at what solution we are going to create. And this is how the journey happened for me. And this is where I said it needs a radical transformation and it needs a redesign of the system, and how it will happen, I will walk you through in the next slides. And part of the going through this journey we partnered with Tabad Lab, which is a think tank based out of Islamabad, to develop a white paper, a policy paper, then how can we achieve universal healthcare in Pakistan? What are the challenges? So it was taking in account of all the challenges that I have elaborated, and in a lot more detail it's given there. And then it follows with actionable agenda, what can be done and how. So here's the link, and if you Google Tabad Lab and Universal Health, the paper will come up, and we had the roundtables around it as well that you can see and at your own leisure. So now, what's the solution? We've all talked about problems. We all tend to highlight problems, and then we don't talk about solutions. This is where I would like to show you this picture, and which we, being from healthcare, I think we're all very familiar with. That there is a continuum of care we are talked about, we are taught about, and we look at that. So if you look at the continuum of care, the acuity level increase, the care becomes more centralized towards tertiary care in specialized hospitals, and then it follows into other post-acute care mechanisms to rehabilitate back into the community or specialized facility. And on the left side, there is a whole preventive curative paradigm, which has an expedited uptake of virtual clinics in the last 2 years, but the remaining chain tends to be the same, where you have increasingly complex level of cares provided at different levels, leading to tertiary care. So this is important to understand, that how the problems that I've highlighted link to this continuum of care, because 80% of our problems are in this area or in this area, while 20% of our problems lie in this that should be treated here. But what has happened is, because of mismatch, because of fragmentation, because of urbanization, the keen focus has always been building, developing tertiary care hospitals. And politically it looks good as well when you announce a 500-bed hospital. Investors personally, when they're investing, especially when diaspora is investing, they feel comfortable with the concept because they understand, and it's a big hospital and so on and so forth. Nothing wrong with that. Again, history is history. And it's hindsight is 2020. But now we have to look at all these areas that have been left out of this picture in terms of the solution. So this is a centralized solution, but all of this has to be decentralized. And as we have seen in the last 2 years, the trend has changed, but there's a lot more to be done and a lot more to be looked into. And this is where, when we look at this continuum of care, we identify that this whole area is empty. There is no coherent investment in this area from private sector that can create an integrated ecosystem that is resolving or helping people solve the problems outside the tertiary care hospital. And it has, as you think about it, you'll see it has multitude of benefits at every level for every stakeholder. Because currently what is happening, the concentration in tertiary care becomes your primary care, your secondary care, your tertiary care hospital. And it does everything at the same time. While you are looking at there is a problem that I can solve at home, or I can solve closer to where I live, or it is something that doesn't need a long length of stay in a hospital. And what happens once you're done with the tertiary care? Currently, family takes you back, but there is a whole healing process that needs to happen after a patient leaves an acute care hospital or acute care settings to get rehabilitated back into the community or into his work and so forth. So this is where, this is the radical part of the solution, is that when you look at a very simple concept that we're all aware of, continuum of care, you look at the opportunity, this whole area lies empty. There is no, again, coherent, integrated effort to address or give a solution that covers all those things. So this is where we started to create a foundation of different elements along the continuum of care, and creating virtual clinics, NoorCare clinics, which I'll describe more, then multi-specialty centers, then the NoorCare hospital, which is a secondary care hospital, and then rehabilitation and home services after that. So let me take a few minutes here and explain to you how it benefits everyone. So this is what we have all heard about, hub and spoke models. We have all heard about where people can get care closer to, but this is a first coherent attempt to create a solution in the private sector in partnership with different organizations to ensure that it's a mutually beneficial, sustainable solution. And what do I mean by that? So for all of the assets we are creating, we have created a foundation where we have brought in certain partners where it becomes mutually beneficial. For example, so retail clinic and the primary care clinic, we are delivering with NoorCare clinic, which is a GP led clinic, purpose-built clinic within the pharmacy, and we are partnered with surveyed pharmacy chain that has 150 branches across Pakistan. Similarly, when we look at the multi-specialty centers, we are looking at developing multi-specialty centers in partnership with other partners who will benefit, whether it's a tertiary care hospital, whether it's another healthcare setting, whether it's another ancillary service provider where we can co-locate these multi-specialty centers, again, within the communities. NoorCare hospital concept is a secondary care hospital, 25 to 50 bed, which if you look in the literature in the States, you would find micro hospitals, which are typically critical access hospitals. So we took that concept among other things and looked at how we can adapt it to the local circumstances and the local demographic, which I've alluded to. And we are creating this 25 to 50 bed hospitals, which can be in second tier city and which can be developed in the urban area, but again, in the community. Similarly, NoorCare Rehab is an at-home service at the moment where we look at rehab and also divide into primary, secondary, tertiary level of rehab. So we are focusing on primary, secondary level of rehab, which can be provided in home. And virtual clinic, we are going through the pilot phase to launch. So if you follow the thought process from left to right, you can see the increasing complexity of care, going to the secondary care, and then partnering with the tertiary care and make them effective as well. Make them more useful because then they have the follow-ups of the patient, they know where the patients are coming from, and so on and so forth. And as you think about it, you'll see how it can have multiple levels of benefits along the way. So as I initially mentioned, the solution has to be clinically, financially beneficial. So for us, it's a network. So network is where we build economies of scale that it helps us do data aggregation, that helps to analyze the trends. And all our clinics and hospital have EMR, a locally developed EMR from day one. So we have data on all the patients and demographics, and we can go by area, by a season, by a month, by day. We can look at what are the patterns, which helps us develop very focused, smart interventions rather than these blanket solutions we portray to be, and we try to them to be successful, but would ultimately are not that effective, as we all know. Being in a network, you can maintain quality because the teams and people and the volumes are high enough that you can have the quality effect of bringing those resources. We have built partnership with tertiary care hospitals to act as their referral sites. But again, the workup is done in the community. You don't have to go to the hospital to find out that you just needed a CBC before you had to see the doctor. All of that is done in the community closer to where you are. The designs are patient-centric. All of our workflows ensure that the patient doesn't have to move and the system moves around the patient. And what I mean by that is the first thing that happens when we get sick is in Pakistan or similar is, let me find someone who knows someone who will call someone to get me an appointment. So Minute clinics, for example, are in your community within the pharmacy. Currently, we have started with 8 hours. We'll expand the hours. No appointments. You can walk in and the GP will see you and you'll be taken into the system from that point onwards. And then if diagnostics are needed and referrals are needed, we take care of that, and patients just gets a phone call to make choices. Because we think when you're sick, this should be least of your worries, that how to get care versus where to go and so on and so forth. Being in the community, we can be very locally and culturally focused. We live in your community, so we know how it is. Later on, the Ehealth and Mhealth technologies can be deployed. We are talking to run a pilot with an academic institution out of Australia for patients with diabetes. And integration is what makes it happen, that patients can go anywhere in the system and they will be able to access their old records, and redundancy and the waste and everything will be removed. So just to give you a glimpse of how it relates, is it something unique to Pakistan? Not really. even the developed countries, the volumes and the trend is moving more and more towards ambulatory or out of the hospital care. And we, people in the States will be familiar that we are continue to hear about big hospitals closing down at times, and the occupancy is no more than 55 to 60%. Hence, the trend is towards outpatient care, which is again present in the community, whether it's digitally or physically. Who is going to make it happen? We have assembled a team that is multiple levels. Obviously, it's myself. As you did the introduction, I just put all the institutions that I've been fortunate to be a part of, whether part of my training, my research, or my professional and academic career. And this is what I've been doing for over 2 decades before I relocated back to Pakistan at the end of 2020 to focus on developing this solution. Here's a team that I picked from the local market. And the idea is to bridge the gap in terms of their understanding and the knowledge I and likes of me bring from outside, to make sure that we give them that confidence in terms of what you're doing and what they have learned and what they are able to do is good enough, or how good enough it is, and give them that confidence. So this is where we are building the team. Currently, we have a team of about 51 people, including physicians. Within 1 year, we've expanded to that point, but all the management on the ground is from the local market. Then I've assembled a global advisory board to provide us that insight, the wisdom, in terms of as we embarked on this journey. And some of these people are personally known to me and have mentored and developed my thought process over the years, and I'm always indebted to their kindness and graciousness to do that. But the idea is also to bring their attention to a country like Pakistan and emerging markets, and highlight to them that what are the solutions, and learn the essence of how the solutions develop in a country like America and other parts of the world, and take the essence of those solutions and bring it to Pakistan, rather than trying to copy paste the solution itself, which may or may not be applicable. Where do we stand? We started Punjab as our initial market. Punjab is, as we know, a province of more than 110 million population, which is bigger than certain countries. So the idea is that if we can work it in Pakistan, in Punjab, then we can replicate not just in Pakistan, but we can create a case for this to be emulated in other countries or markets of similar size and similar challenges. Where we are today, we are in 4 cities, Sialkot, Lahore, Multan, and Rajanpur. We have 16-minute clinics up and running in Sialkot, Lahore, and Multan. Rehab services are running in Lahore. Soon we'll be expanding. Rajanpur, our first micro hospital. The OPD is open. Mother and Child Limited is open as of this month. And Alhamdulillah, we've already delivered 2 babies, which people had to travel to Multan or Rahim Yar Khan or other areas. They just walked out to their home, 5-minute drive to the hospital, got the baby delivered, and they were back home next day among the loved ones, which is a blessing in itself, which I believe in. Here are some of the snapshots to show you how a minute clinic, actual minute clinics look like. So you can see it from the concept of the bottom left to the minute clinic execution. This is exactly how it looks. We have completely made it as much as possible digital. So even the equipment is digital. We didn't put the regular manual things because we want later on to integrate these machines into the EMR system. Here's a schematic of the multi-specialty clinic that we are developing at the moment, 2 locations in Lahore, which will have 3 to 5 physicians and ancillary services and so forth. Here's, if I can show you, the yellow is the design. When I started working with the architects, this is how the current hospital looks like, the OPD, the main section, and then IPD. Here is the team that is, which I'm very proud to say, is all hired from the local city, which was one of the hypotheses I had when I started. People said, you will not find human capital. And my hypothesis was, if you create an infrastructure in that city, people will join and people will find ways, will welcome that. And that's exactly what has happened. So we have about 25 people on the ground. They're all from the local market, including physicians, consultants, therapists, technologists, nursing, front desk, everyone. And these are the actual pictures of our pharmacy, the lab. We have a physio gym in the OPD. This is how the OPD looks like. And inpatient and the main section is behind this building, as I said. So quickly going to, is this only for Pakistan? I'll show you some of the recent trends from the US market, where you can see the focus in terms of growth, focus in terms of EBITDA margins is moving towards outpatient services. And this is a McKinsey report publicly available. If you Google it, it will show up. But if you look at the dark blue, the growth in the light blue, it's happening in mostly services that are outside the hospital. And projected EBITDA of healthcare services and technology segments, again, is focusing more and more home-based services. This is mainly to illustrate that this is not something that's happening on Pakistan only. My apologies for the background announcement. The top section shows you the percentage growth of the sector that will have more than 5% growth. If you look at it, primary care, physicians, telemedicine, on-site clinics, dialysis, behavioral health, retail clinics, all of this is our outpatient, because inpatient care is becoming complex, expensive, sometimes it backfires. And this is when I looked at the data, that how people are collaborating, companies are collaborating to create these networks in terms of between digital and provider, digital and digital, provider and pharmacies. These are recent deals that have happened in America, billions of dollars. And I'll show you the companies that have done it. The most recent one, which probably you have heard, is One Medical, which was acquired by Amazon. It's a primary care network across US that has been acquired for $3.9 billion. And if you look at all these companies that I've highlighted, they're all in the primary care space in the US. And what they're doing is they're networking, they're collaborating, they're doing a joint ventures, different levels of relationship with other organizations to build that continuum of care, which I initially talked about. On the public sector side, the government side, there is a push to adopt more and more of primary care. And you can see this is a map showing where each state stand and where the push is coming. And I think about 2 weeks or 3 weeks ago, California launched a primary care initiative where most of the state institutions signed up as well. So one thing I want to highlight here is the question can become that, these are very practically primary care focused organizations. Why are we doing more than primary care and getting to secondary care? And this is where, the financial sustainability becomes more credible and more sizable when you lump primary and secondary care together. And because of not having any legacy network, we get to leapfrog and we get to create a solution that we are creating this, including primary and secondary care together, which will help with both short-term and long-term sustainability. This is what it is. Where we stand apart from this is we have just started the fundraising. We are hoping to raise $5 million over the next 6 to 9 months, whichever time it takes. Here's my contact details. And once again, thank you. Really appreciate everyone giving this opportunity and providing a platform. I wanted to finish in time to have more time for question and answers, and we'll be more than happy to answer any questions. Thank you very much.
Thank you very much, Dr. Muhammad Ali. A wonderful initiative. So there are so many questions because when you are innovator, you have to create your own pathway. And then, there is a brigade of all the issues, like the obstacles, they are on their way. Because a lot of international physicians, when they go back, they do not see a comparable infrastructure and they face a lot of problem because, if they have spent 2-3 decades in the international market and when they go back, everything is changed. So first of all, they need to synchronize with the local ecosystem. So what's your feeling? Because when you decide to go back, say like after 20 years, what was your first reaction in terms of infrastructure, in terms of human resource, and how supportive or otherwise it was when you open up your initiative? Would you like to share some of your thoughts?
Absolutely. So, one thing which I mentioned initially as well, and I advise or guide, or I would, give this advice to everyone. Relearn Pakistan. If you want to go back, relearn Pakistan. Don't go with the notion of where you left 20 years ago. I left in 2002. I moved back in 2020. I've been visiting Pakistan through and through and have been involved in some things. So I relearned Pakistan as well. What I tell people is, which I did myself, is I did not look for a US healthcare system in Pakistan. I looked at what are people trying to do here? Are they achieving the outcome? We talk about value-based care. We talk about outcome-based care. I changed the lens and I said, let me see how good or bad they are. Because until you realize that based on the circumstances, based on their challenges, they have found a solution. Let's be agnostic for a second to that solution being good or bad, but they have found a solution. This is where the innovation is happening on the daily basis. Our benefit or our addition to that is go back, look at the innovation, and see how good or bad it is. Because they have not seen the US the way you have, or I have seen, or being in the system for long. So I told them when I went back, I said, look, what you're doing is about 50, 60% good. Let me take you from the 60 to 80, 90%. And here it's how it's going to happen. So take the essence of what you've learned and what you've seen in the US or any Western country and try to match it to the local circumstances. But that person who's practicing on the ground, believe me, he has done it. What he is not understanding is how good or bad it is. And secondly, in terms of human capital, the biggest challenge I've seen is not the lack of scale or lack of availability or others. It was the lack of role modeling. The first question when I hired these young physicians, 2 years of house job, I said, what are you going to do? I couldn't believe myself. 20 years later, the answer was neurosurgeon, cardiothoracic surgeon, cardiologist. These were three. And I'm talking about being in Lahore. Forget about that at smaller cities now. I'm talking about Lahore where they have exposure, they have everything. And I said, why? I could have said, no, what are you talking about? I said, no, why are you saying that? Their response was very naive and very innocent. They said, sir, this is all what we have seen when the professors come and tell us. We don't have a role model to look at. You are the first person who's asking us, what do you want to do with your life? And this is where an awakening happens on our part, on my part, that it's not that they don't want to do it. It's that they never had the opportunity and they were not the fortunate ones who could leave. So when you go back, take the essence of what you have learned, which is what we have learned in the States, right? Transparency, ethical, honest, kindness, empathy, honesty, trust. Why do we forget when we go back? This is what I went back with, and it was awakening on a daily basis for me, because I have worked across 3 continents right now, right? I have worked I grew up in Pakistan, lived in America for 10 years, lived in GCC, which is the most resourceful countries in the world. And I can tell you one thing, the problems, the nature of problems remain the same across 3 markets I've operated. It's the scale that will change. Is it not bureaucratic in the States? Sometimes it is. Is it not bureaucratic in the Middle East? It is. But have they done it? Yes, we find a way around it. Hence, the point is, take the essence of back, listen to the people on the ground, and ask them what do they want, and then bridge that, because that will make it sustainable. I showed you these 4 people I took from the local market. None of them have a healthcare background. Where would I find in the price healthcare managers? And one of them went through the construction and is running the hospital now because with the confidence he has got. So this is why I look at, you can say it's a perennial optimist. I look at glass half full, and I look at the people and say, let me learn about why you're thinking the way you're thinking and help you think it through. And that's where the magic sort of happens. That's where the awakening happens.
Excellent. So in your first few slides, you mentioned the disease burden study, and in that you mentioned like 50% diseases, they are the mental health care. So do you see that you can incorporate some real component of mental health care, well-being in your system, and how are you going to deliver the mental health care in your system?
So this is where, what I mentioned is, if you look at the concept of being in the micro community, being present in the community helps you break that taboo. Because it's a GP clinic, anyone can walk in, and we are seeing patients with depression walking in as well. Versus, oh, you have to go to a psych clinic halfway around the city to another physician, which will take 2 months to get an appointment. Who's going to get mental health and who's going to do it? So we have seen patients with depression, and this is where we are looking at focus by area as well. That why is it happening in certain areas versus the others, right? So instead of me trying to do mental health across the network, I have a very focused approach, and we are talking to people that do your clinics in the community and come out, and it's a GP clinic, so the taboo is gone that you are walking into a psych clinic and what are you going to go and you'll become crazy after this, all those taboos that we have. Being close in the community, the GP clinic breaks that taboo. At least it gets you in the system to identify that you're at risk of mental health challenges or you are facing challenges. And we are seeing depression among both male, female age groups as well.
Okay. So you also mentioned that, just 1% of the GDP is spent by the public sector and 2% of the GDP expenses from the private sector. So is there any mechanism really to take advantage of the failing healthcare infrastructure in the public sector? Is there any mechanism to bridge and, create any type of synergy with the public healthcare system?
So this is where I'll tell you what my approach has been. My approach is, let me build a solution in the private sector first. I would not build it dependent on the public sector or the public support or the government support, because that is again a recipe for failure to begin with. So I have built in parallel, and now we say to them, look, if this is something you like and you would want us to work as any tertiary care hospital, we'll work with you as well. And the same thing, that we can be the community arm for these referral centers, the tertiary care hospitals in the public sector. This is purely from my perspective, looking at the public hospitals. It will make them efficient, make them effective. They will have the less burden of seeing these primary care patients walking in, clogging the OPD and ER and so on and so forth. So this is why we are looking now to enhance our timings, and we want to expand it to like a full day, full 24, 23-hour clinic where people can walk in at any time. I think that will help the public sector from our perspective. The second part of it is, it also helps public sector or private sector in terms of designing what services they need to offer. If the challenge is lifestyle disorders and you keep offering every possible specialty under the sky in your 200-bed hospital, how are you going to be effective in any of that? We know that the center of excellence concept, this, pick few specialties that are pertinent to the community and be excellent in that and share that with other areas as well. The third part of working with a think tank is for that reason, that we're not just talking about, look, I'm a private sector, I'm only interested in my own profits. We did this white paper that's applicable to everyone, because I believe that when the tide is going to rise, it's going to rise for everyone. And now we are working on a second paper, which is about healthcare financing and investments with them, that how can we create a framework around where we can enhance. And I can go into details of, how public sector and the government sector does not recognize healthcare as a service industry and how we are at a disadvantage of, access to public funds or loans and so on and so forth.
Right. So as you know that as of today, in terms of infrastructure, the public health, their only model, as you mentioned, is like building the tertiary care hospital because of some political advantages. And the neglected stuff is the primary health care. And the burden is shifting to the tertiary care hospital because there is no segregation, and many of the primary healthcare people, they are approaching to them. So do you see that an effective analysis and rationalization of the resources and healthcare delivery can create some advantage? So that's the policy perspective. You mentioned that you You were part of a policy paper, and I will definitely have a look to that. Do you see that it is not only the resource limitation, but also the proper rationalization and matching, as you mentioned from your community model, that the service should be provided based on the local community need. So, what's your take on that?
Yeah, so this is where mismatch comes in. What is happening is a mismatch of resources, mismatch of understanding of the demand and supply, and mismatch of human resource getting all centrally located into one place, and they all want to work at the tertiary care hospital. They only get trained there. So this is where we're doing the public policy work as well, and telling that, look, there is the existing infrastructure. Forget about the new infrastructure that needs to be built, because we know that developing a hospital is a 5 to 10 year journey. I'm talking about the existing infrastructure. Let's make it more effective and efficient by doing these interventions at the community level and outside the hospital and incentivizing them. So we will be prescribing some of these elements, because right now, for example, the universal health coverage under Safe and Soft Card is incentivizing to do inpatient care only. It does not do outpatient. We are talking to the insurance companies because OPD is the most neglected segment. 38% penetration in Pakistan's market is insurance. We're talking to insurance companies and say, look, current practice is you give a lump sum amount and see when it expires, it expires, versus understanding about the problem, which is 80% of the issue and what people are doing. So we're talking to them and developing solutions around insurance for these OPD-based services with them as well. And this is where, again, going back to primary and secondary, when you lump them together, you really address the issue, because otherwise you leave them, if you do only primary care, you leave them to the same public sector again for surgical interventions, for advanced treatments, which again in the Western world has become, the ambulatory care that gets done on a daily basis, which still is inpatient care here.
Great. So my next question is, as you know, you are working on the policy level as well, and you mentioned the role model deficit in Pakistan. So our curricula at the undergraduate level is more tilted towards the specialties, and there is a lack of focus on the community medicine. So do you suggest some intervention at the curricular development, because there is a continuous activity, they are revamping the undergraduate curricula? So do you see, is there any difference you can create by focusing more towards the community medicine part of it?
So this is where we are developing not just a policy level intervention, but also, until there are employment opportunities, you don't have the incentive to go into that particular field, and people will not be incentivized. So being these micro hospitals and others being in the community, we are enabling local human capital to get into allied health, for example, and have an employment opportunity closer to where where their home is, which makes it affordable for them as well. Otherwise, going into that field and living in a big city, it's almost impossible, and they will skip it and go to something else. So that's at the later end of it. At the earlier end of it is what we're looking at is to develop these curricula in partnership with people who are already offering allied health, these education, and say, look, let's make it more practical. We are working on developing nursing training programs focused on not the BSN program, not the the diploma programs, but once all of that has been done, what happens is the mismatch between the skill set and the practical execution on the ground. And this is where we're working with, and as you can see in our advisory board, we have an esteemed nursing faculty from around the world as part of our advisory board. And one of them, a very dear colleague, she is personally talking to nurses on a daily basis in a hospital in Rajanpur, which was impossible before. That a former CNR Hopkins talking on a daily basis to nurses in Rajanpur and telling them how you can take care of your patients better. This is the transformation we're talking about. This is where we're helping them learn the skills. And then, curriculum is the longer term change that needs to happen, and we'll be working with private sector first, because they are more agile, they're more quick to respond and action, and we can develop these programs quickly with them in the short term, and then later on with the public sector.
So, that's my last question is, are you facing the good supply chain for the delivery of services? I mean, you need to have the disposables, the inputs, the medicines. So what's your take on that? Do you see it's in perfect condition to support your thinking and your healthcare delivery, or it is patchy and then there are dry out period and you need to create a buffers, or it's in optimal situation? What's your thought on that?
So, the supply chain in terms of the material and consumables,
Yes.
keeping in mind that our solutions are simple. We are, again, primary and secondary care. We are relying on equipment, we're relying on the consumables that are locally produced as well. So for us, that challenge of disruption in supply chains globally, which has led to delays and backlogs and so forth, is not impacting us that much. Because even the medicines we are giving, they're locally produced, and they're generically produced as well. And this is where we are able to ensure that we still are delivering care at par in terms of quality. And this is what we are making sure that we tap into the local market, develop a redundant supply chain platform with multiple vendors. And so far, I haven't seen any big challenge when it comes to that, whether it was equipment, whether it was consumables, and so forth.
Right. So there is a question as well. Somebody asked that how viable is this commercial model? Because it's in the private sector, it should be sustainable and it should be evolving, and you are raising some capital. So how do you see its growth in the coming year, like 5 to 10 years? Where do you see,
Yeah. So in terms of commercial viability, this is where when you look at us, and that's why we have created a network of, yes, primary care, as we all have this, understanding that primary care is usually loss making, where part of any healthcare system. That's why, so I'll explain to the rationale behind the financial viability. One is combining primary and secondary care makes it viable to begin with. Because secondary care, we all know it's financially viable. Even in Pakistan, these hospitals, 25, 50-bed hospital are viable across board. So by combining them in one network, we are able to create that viability. That's one thing. Secondly, by creating partnerships, I cannot offer a 300 rupee primary GP care consultation on MM Alam Road or DHA if I have to build my own infrastructure. Impossible. I cannot do that. That's why we partnered with the pharmacy. We said, you already have the real estate. We'll take it from you. We'll carve out a part, build a purpose-built clinic with no conflict of interest, different contract, and we'll offer care where people are closer to, and it helps them as well because they already have a footfall. We'll leverage that, and then we'll leverage the additional population coming into those as well. So my running costs on a daily basis, I don't have an investment in a real estate to buy the land or lease the land. I don't have the investment to build a physical cement, brick and mortar infrastructure for those primary care clinics. And I don't have the similar level of running expense that you would have if you were to build a purely primary care clinic. I could have stopped there and said, no, I cannot do it because I need to have 3-5 physicians, a land, I have to have land or leased commercial space before. This is where, again, the transformation of how you think about it. I looked around and I found like-minded people who said, yes, we have tried, didn't work, but let's try it with you because you are a physician. So this is where it makes the cost structure. For example, I can tell you, if I see 9 to 10 patients per day in these minute clinics, I become commercially viable, which is not an unthinkable number.
Impressive, impressive. So Dr. Umariyat, unmute yourself and please, comment. And if you have any question, please do coordinate.
Very much. I think, as you asked, very relevant question, and that's really your field of expertise. I have only a few questions. First of all, wonderful presentation. I think a great business model, and I wish you the best of luck. And I think there is a lot of room for this business model to be applied in Pakistan. My first question is, have you considered or how it applies to the rural areas?
Yes, so Rajanpur is officially the most backward district in Punjab, and the reason I started there, I come from there, I have ancestral village as well. So I said to myself, and I'll frankly say, I said, I'll start here. If it doesn't work, nobody will notice. So, I will run it as it is, and it'll be fine. But when you look at the data, the healthcare spend is equal between rural and urban areas in Pakistan. Actually, rural areas tend to spend a little bit more because of the additional cost. So that's one thing. Secondly, the way we have built it, because of the local human capital, our cost structures are low as well. I cannot hire the same person in Lahore for the same salary that I can hire in Rajasthan for that. Yes, the consultation may be lower as well, but the cost structure is lower as well. Third thing is, people become cognizant of the fact when they see the quality that, look, if I'm going to spend this plus this, if I go to another city, I will spend 50% of the additional here as well, and I can do it. And we are offering the service in comparison to others. We're not that far off in terms of probably maybe 10% higher compared to the local mom and pop shops, because we can do that. And the third thing is, again, this is how you design the business models and how you structure the business is important as well. If I structure the business that every cost is loaded up onto that single hospital, I couldn't do it. But now, since we have a network, I can hire a person in Lahore that can and buy 30% of their time to do something in Rajapur, which would have costed me 150% to convince that person to go there and give him.
I will put in a slightly different way, because I think there is a need as well. So there is a need and opportunity. So I think your business model probably will work even better in the rural areas than in places where you have to face a lot of competition with the open mom shops. So the other question I was thinking through your presentation was, like, it's literally when it comes to the healthcare and the service. I mean, the word service is always missing in Pakistan. So it's three components. I mean, it's a patient, it's a healthcare provider, and then of course the medicine. And the quality of the medicine. I mean, you mentioned the word generic, and in Pakistan, nobody does even the bioequivalency to prove this is an effective generic. So have you considered like the quality of the medicine in that whole scenario?
Mm-hmm. So the way we verify some of these quality elements is two ways. One is obviously the market reputation and looking at the corporate structures of mom and pop versus, hence the partnership with a corporate pharmacy chain, and we're exploring more of that as well. And the third thing is the experts we have internationally. We also work with them to look at some of the outcomes we have achieved with these medicines and others, and say, look, does it jive with what you think in your field, and so forth? Because chemically, obviously, no one can do anything. So we look at the outcomes, we look at the reputational element, and we look at the processes of that corporate element to make sure that we do this. And that only happens, again, going back to, because as a network, you can talk to these corporates and they will have enough volumes to have a conversation with you, versus a single hospital trying to talk to a corporate medical, pharmaceutical manufacturer or delivery system in Lahore. It's impossible to do that.
Thank you. Thank you very much. Hussain, I'm going to get back to you because we have questions from the audience. So you would like to address those?
Yeah. So first question is Mr. Izhar Hassan. So he has raised his hand. Please unmute yourself and please ask the question directly. What do you have? Please unmute yourself and ask the question. You have raised your hand. Mr. Izhar Hassan. Walid, can you unmute Izhar Hassan? Yes, please go ahead.
Hi, can you hear me now?
Yeah, perfect.
Okay. Thank you so much for taking my question, Dr. Uzair. Very nice to see you again, and Omar as well. Dr. Ali, that was an excellent and what a timely intervention or initiative you're taking over there. I have a background in urgent care and family medicine, so I can totally relate to that. Question is, you mentioned about the EMR implementation, all these things. So how's your evidence-based healthcare is going over there in intervening these patient population? I think that's one of the things I would be interested to know.
Sure. So Thank you very much. And as you alluded, EMR, the reason to put EMR from day one was that we can do evidence-based practice. Because if it's on paper, I cannot hold anyone, or I cannot see what the patterns are. So with EMR investment from the get-go, we're able to see what the patterns are, what kind of disease we are seeing, what kind of medicines we are prescribing, what kind of diagnostics we are prescribing, and so forth. So that's one. Secondly, we are working both internally and externally to develop order sets, because primary and secondary care, as we know, it runs on volumes and the margins on the volumes and standardization of care as much as it is. And the reason I mentioned the business aspect of it is because that financial sustainability is key. It may look nice to invest million and get something, but if it's not sustainable, it's not going to make an impact. That's why we're looking at order sets that we develop based on the evidence, and then we test it in the system. And with an EMR, we know how the variation is coming. Is it working ideally right now? No, it obviously it has its own growing challenges and learning lessons along the way. But we are doing that on an ongoing basis, looking at the practice against the order sets, looking at the variation, because that could be a positive variation as well. So we want to learn about the community and make changes which are locally applicable and adaptable.
Also, a follow-up question on the same line. So have you thought about automating the care? As you can imagine, right, the next big move is towards the automation of the healthcare. A lot of AI-based applications are already out there, at least in the US areas, because of the automation of the most primary care-based decisions for healthcare. So have you looked into that, obviously, because you're going to be a pioneer anyway. So you might as well try to do that component from ML and AI-based early part to kind of more further standardize the care, not the cookbook medicine, but I think it is the way everyone is adopting anyway. So you wouldn't be an exception to the rule.
Mm-hmm. So there are two elements to that. One is that's why we did the EMR, so we can have the data, because once you have the data, you can do all of these interventions onto the data. Secondly is being present in the community gives us that local understanding that I can understand. Because one of the key elements for me to understand from all of this is how do people make decisions about healthcare in emerging markets? Nobody has answered that question so far. So I want to learn that with all these advanced tools, and we're having discussions as we are building database to apply those and understand the patterns and what people are doing, how the decisions making, because that has way more impact in terms of how we grow as a society. And ultimately, if I have a vision to get to a point that I have the data and the tools to apply it, maybe we can offer it free to people in terms of healthcare, because the data is a lot more valuable than anything that we get in terms of the consultation fee. That's the vision, not the short-term business reality.
Yeah, I don't want to be air hogger, but the last question, and I'll leave, I promise. What is the equity partnership process you have in place for raising your funds?
So we are, as I said, our initial raise is 5 million, and you have my contact details for the discussions. We'll make sure that the companies are already registered from day one, so we have all the audits and records and legals and so forth in place. And we're also, I have started the process to incorporate in Delaware and other international entities as the investors' choice becomes more crystal.
Thank you.
Thank you very much, Dr. Muhammad Ali. What a thought-provoking discussion and interaction and idea. So we are thankful to you. I know you are sitting in Dubai airport. It's a big challenge, keeping the noise level low and at the same time focus and concentrate. And we are grateful for your time and for your thought. And we are also thankful to all the participants for a wonderful comment, question, knowledgeable engagement, and everyone. So with this, I may say goodbye and thanks again to all of you. We are a little bit over time. So thank you very much, and all the best wishes to all of you.
Thank you very much. Really appreciate it. And thank you for everyone listening in. Allah Hafiz.